So the aim of this lecture is to discuss the preoperative assessment in order to plan the surgery in patients with deep endometriosis. And here you have my disclosure of conflict of interest. Okay, so I had two conflict of interest because I'm involved in research founded by Nordic Pharma, and I'm involved in training organized by Plasma Surgical. So the objectives of my lecture are to discuss the diagnostic accuracy of various imaging techniques for deep endometriosis, and also to try to assess the usefulness of different techniques in preoperative planning and the choice of different surgical techniques. And at the end, to discuss some particular situations where the careful preoperative assessment seems mandatory. So when the preoperative assessment starts, and in my opinion it starts with on the first visit, and one says that to diagnose a large number of deep endometriosis, the physician needs 2 ears and 2 fingers. And why 2 ears? Just to listen, for listening, patients' complaints. And as you know, the patients with deep endometriosis, even though the endometriosis is huge, the patient is still young, and the most of patients in our series, their age is around 30. And usually they present with several kind of pain. However, several typical pains may miss. For example, the dyspareunia, deep dyspareunia is not a rule, and even in patients with very large nodule infiltrating the vagina. Also, the patients with bowel involvement may present with several symptoms such as diarrhea, constipation, dyschezia, bloating, and even subocclusion. Another problem concerns the ureteral involvement, which is often asymptomatic with a huge risk of kidney atrophy. Also, the sciatic and pudendal pain may reveal sacral roots involvement, especially when they are unilateral. And special mention for the dysuria, which is a very progressive and overlooked symptom. And it is very useful to check preoperatively the post-voiding bladder volume in order to be sure that an impairment is not due to the surgery, but rather to the disease. Then we have the physical examination, and where we use our fingers, and we can feel a tenderness of the vaginal cul-de-sac, posterior vaginal cul-de-sac, when the nodule is high. It's on the upper rectum or the sigmoid colon, but we can feel the nodule in the posterior vagina when we have a rectovaginal nodule. We may have an immobility of the cervix in frozen pelvis on the huge nodules, and we also could, in theory, see the nodule, but the problem is that the patients are useful and it is difficult to open enough the speculum, so these beautiful pictures are systematically taken in the operative room when the patient is under general anesthesia. As regards the specific lab exams that Professor Falcone told that a couple of minutes ago that we have no exam, no accurate diagnosis, neither in the blood nor in the urine to check, to assess the diagnosis or to predict the severity of the disease. Now let's come to the imaging modalities for deep endometriosis. And as you know, we have various methods of imaging, and there are a couple of studies concerning each one, and the results are so heterogeneous, and ultimately the value depends on the radiologist, on the experience of the radiologist you have in your team. So first exam is the ultrasound. So there are several technicals ultrasound, the transvaginal ultrasound, with or without bowel preparation, the rectal water contrast, sonovaginography, the tenderness guided transvaginal ultrasound, the 3D ultrasound, and also the endorectal transrectal ultrasound. MRI is a major exam in endometriosis, and I feel that the physicians discovered the endometriosis once the MRI could provide the sections in various planes. So I feel that at that moment, the knowledge about the deep endometriosis considerably improved, so 20 years ago. So there are various techniques of MRI with suppression of the fat signal with jelly method, and you can see that the images are very useful. And we have a very good knowledge about the extension of the disease. Here you see a patient with a disease going through the sacral roots on both sides. And here you can see very well the nodule, and we can explain, you can show it to the patient, so the patient may understand how kind of disease she has and what is the goal of the surgery. And there are also other techniques. So in Rouen, we systematically or routinely use the computed tomography-based virtual colonoscopy. Other teams use the multi-slide computed tomography or double contrast barium edema. But now, let's see what is the accuracy of each exam. And in the literature, there are several studies focusing on ultrasound, on MRI, trying to compare their value. And the study were recently pooled in meta-analysis available in Cochrane database, which goal was to provide the estimates of the diagnostic accuracy of imaging modalities for pelvic endometriosis. And the authors took the surgical diagnosis as a reference standard. As regards the transvaginal ultrasound in deep endometriosis, they pulled data from 9 studies and 12 data sets in almost 1,000 patients with deep endometriosis. And they observed that the sensitivity is around 0.8 and the specificity 0.94, meaning that the transvaginal ultrasound may be a spin triage test in uterosacral ligaments, rectovaginal septum, the vaginal wall, the Douglas Ploch obliteration, and rectosigmoid. And spin triage test, meaning that due to the high specificity, when the test is positive, it rules in the pathology. Meaning you have, in transvaginal ultrasound, you see a nodule, it means that it exists. As regards the MRI, there are 6 studies and 7 data sets with 260 patients. The sensitivity is 0.94, the specificity 0.77. So the MRI approached the criteria for a snout triage test, meaning that if the MRI is negative, it means that probably the deep endometriosis does not exist. While the MRI could be also a spin triage test for Douglas Ploch for vaginal and rectosigmoid endometriosis, meaning that if it is positive, it means that the disease exists. As regards the transrectal and rectal ultrasound and CT scan, both are very useful for the bowel endometriosis, specifically bowel endometriosis, and they have the qualities for a spin test and the CT scan for a snout test, meaning that they could be used in addition to previous exams in patients with bowel endometriosis. However, the meta-analysis concluded that none of imaging modalities are able to to detect all the localization of deep endometriosis. And unfortunately, there are not conclusions about the association of different imaging techniques. And the rectosigmoid endometriosis is the only localization where the transvaginal ultrasound, transrectal ultrasound, the MRI, and the computed scan are very useful. However, it is difficult to perform meta-analysis on this study because there is a large heterogeneity in localizations and data. So the results should be interpreted with caution. Now the question is, we have the imaging techniques, but what information a surgeon like me or you need to plan the surgery? So I think that one of the parameters we should know, we like to know before planning the surgery, is the length of the bowel infiltration. And the length is the major decision for a surgeon who tries to choose between a disc excision and a segmental resection. And why? Because if he used to perform a disc excision using a circular stapler, he cannot do it if the length of the infiltration of the bowel is over 3 centimeters. So, in this case, he will use rather the colorectal resection. And if he used the Rouen technique, so the Rouen technique is a technique of transanal resection, transanal disc excision of large, deep endometriosis of the low and mid rectum. So we cannot do this technique if the length of the infiltration is over 6 centimeters. So we need this information. And this information, the length, is very different from the diameter of the nodule, because here you can see that we have 3 nodules where the diameter is the same. However, the length of the infiltration is very different. So here you have the length of the infiltration much larger than the diameter of the nodule. And why the length is important? Because once you shave the rectum, the diameter disappears, and you have the length to manage by disc excision or colorectal resection. So the length. The second information is the high of rectal infiltration. And this is a very important parameter because it can predict the unfavorable functional outcomes if you perform a segmental resection. Because the colorectal surgeons are aware about the low anterior rectal resection syndrome, which is a postoperative syndrome following the low colorectal resection, which may be unbearable for young patients and may lead to anal incontinence or very, very frequent stools with urgency. Also, the high of the rectal infiltration allows us in Rouen to estimate whether or not the Rouen technique is feasible, because if the infiltration is over 9 centimeters on high, we cannot catch the nodule to remove it through the anus. And the best exam to measure the high of the rectal infiltration are the scan and the MRI. And to be more demonstrative, here you have 2 patients with huge nodules of the mid-rectum. Then this one, the nodule is actually very large. However, we could manage it by a disc excision. And 1 year after the surgery, the patient has normal bowel movement and normal continence. She's doing very well. This other patient had a colorectal resection because the nodule on the rectal nodule was close to a sigmoid colon nodule, so we could not perform 2 disc excisions. So we had to do a low colorectal resection. The colorectal anastomosis is 4 centimeters above the anus. So 10 months after the surgery, she had a low anterior resection syndrome. So she has 10 to 15 stools a day and a huge urgency. So the quality of life is actually impaired by our surgery. The third parameter is the stenosis. The degree of the stenosis, oh, I'm sorry, but we miss the photo, I don't know why. So the the degree of the stenosis also determines the type of the procedure you can perform. Because if you have a stenosis up to 30% of the lumen, you can perform a shaving, especially when the patient is elderly. In 30 to 50% or even 80% if you perform a wrong technique, you can still perform a disc excision. But if the stenosis is more important, I think that the colorectal resection is the unique technique suitable in this patient. And the best exam to estimate the stenosis, to measure the stenosis, is the CT scan, because it uses the distension of the lumen by carbon dioxide, so you can actually measure the distensibility of the colon. Well, now who needs this kind of preoperative assessment and why? And it is obvious that the surgeons who treat all deep endometriosis infiltrating the rectum by colorectal resection do not need all this exam, because they need only one information. Is the muscular layer of the rectum infiltrated or not? So they can use either a transvaginal ultrasound or an MRI if there is an infiltration of the muscular layer, colorectal resection, and this finish. So in this case, actually one exam is enough. Conversely, if the surgeons use several techniques, as we do in Rouen, here you have a histogram with my colorectal activity in 2015. You can see that I managed 121 patients with colorectal endometriosis during this year, and 1/3 of them had the shaving, 1/3 had a disc excision, and 40% had a segmental resection. 60% of patients had the conservative procedure. And to prepare, to plan my surgery, I needed this preoperative assessment in order to know very well which is the length, the height, and the stenosis related to each lesion. And furthermore, when I had a look back, I saw that in 92% of cases, I actually performed what I planned, meaning that the preoperative assessment was rather good. If the surgeon planned to perform a shaving, meaning that he wants to macroscopically remove the disease as complete as possible without opening the bowel, I think that the most important parameter is the depth, because the depth will tell you which is the thickness of the rectal wall you leave behind after the shaving. So in this case, if you plan a shaving, I think the transrectal ultrasound or a transvaginal ultrasound are mandatory, in order to be sure that you do not increase the risk of postoperative fistula after a deep shaving. Also, the length and the stenosis are important, and they can be measured by MRI and CT scan. If the surgeon plans a disc excision, I think that the most important parameter is the length of the involvement. Because, as I told you, if the lesion measures more than 3 centimeters, you cannot completely remove it by disc excision using the circular stapler. And if it measures more than 6 to 7 centimeter length, it is huge, 6 to 7 centimeters, you cannot perform a Rouen technique, because it's more likely that the disc excision will not be complete. And second parameter is the height, because as I told you, the Rouen technique is feasible when the height of the lesion is up to 9 centimeters, but also disc excision using the circular stapler cannot be performed in nodule located more than 18 centimeters above the annulus, because this is the length of the stapler. So in nodules located at 20 or 25, you can remove them safely by a suprapubic incision. If you plan a colorectal segmental resection, several several informations or useful. The height of the bowel infiltration in order to anticipate whether or not you may have low anterior resection syndrome. And if the low anterior resection syndrome is very likely because the lesion is down to 3 centimeters above the annulus, maybe it's better not to perform the colorectal resection, to perform an incomplete shaving, and maybe the digestive function will be better with some gram of endometriosis than without the low rectum. Also, it is very important to know if you have an infiltration of the cecum of the ileum of the upper rectum, because in this case, the colorectal resection, the functional outcomes of colorectal resection or bowel resection may be acceptable. And now there are some, I will finish by some particular circumstances where I think the preoperative assessment is mandatory. So you must know the features of the deep endometriosis. For example, you have a young patient with bowel endometriosis and you decide to refer her for IVF in order to get pregnant before the surgery. So I think it is very important to be sure that this patient is not at risk of occlusion during 1, 2, or 3 IVF procedure. And I have published 2 years ago a paper, a series of 12 patients with subocclusive lesions managed after an advice favorable to IVF. And the publication was in January 2015, but now I have stopped to count these patients because it may be over 30. So this is a frequent situation, especially in a tertiary referral center. So I think if we have a bowel endometriosis, we have to, and we feel that the lesion is important, we have to check the stenosis and the risk of occlusion, and not just say, oh, the nodules do not grow very fast, and occlusion is a very, very rare event. It is not rare at all. I think also it is important to, there are two pictures missed. There is also important when you suspect to have a frozen pelvis and you want to refer the patient to IVF. I think you have to assess the disease because the punction, the oocyte retrieval, may be risky in patients with frozen pelvis because you can induce an abscess, an hemorrhage, a peritonitis. And here is missed a picture about a patient, 26-year patient. There's what a catastrophic situation. She had 6 unsuccessful IVF, and they led to 2 open surgery, 1 for peritonitis, 1 for hemoperitoneum, and then with 2 scars, she was referred to us with a subocclusion because there was a huge stenosis, and we had to handle with this antecedents, and I think that this situation would have been avoided if the preoperative assessment, if the assessment of the disease had been done. You have also to keep in mind that 6% of patients with colorectal endometriosis may also have a localization of the ileum and the cecum, and if the localization is on the ileo-sacral junction, it may also lead to occlusion. So it is important to have an idea about this kind of localization, especially in patients with blotting during the period. And the CT scan and MRI are useful for this. And CT scan may be better than, the MRI. And this patient will require a second resection. If you perform a procedure on the rectum, you will add another one on the ileum or cecum. So it means that you add a suture which may present some complications such as leakage or diarrhea because the absorption of biliary acid is less. And it is better to preoperatively inform the patient about this eventuality. Another situation, very tender problem, is that of the ureteral endometriosis. If you have an endometriosis, it may progress laterally, and in this case, the ureter may be involved. The problem is that the involvement of the ureter may be asymptomatic for years and years. And the stenosis of the ureter will lead to a ureter dilatation, to a hydronephrosis, and the atrophy of the kidney, and without many symptoms. The problem with the preoperative assessment in patients with ureteral endometriosis is that we cannot predict the feasibility of the surgery. So I am never able to predict if I will perform an ureterolysis or if I have to cut the ureter, because our exam do not allow us to predict this. And in our series, with dilatation of the ureters, we could perform 78% ureterolysis and only 22% of ureter resection. And as you can see here, there are 4 pictures. The hydronephrosis is quite similar. However, in this patient, we could perform an ureterolysis, and she's very well 2 years after the surgery. In this patient, we had to resect 1 centimeter of ureter with end-to-end anastomosis. The outcomes were very well. In this case, this patient had a reimplantation, and this patient, we did not, I wrote nephrectomy. In fact, we left the ureter, we cut the ureter, and we abandoned the kidney because it was not functional. And if you have hydronephrosis, I think it is very useful to perform a scintigraphy in order to have an idea about the residual function of the kidney. And if this residual function is inferior to 5% or to 7%, maybe it is better to sacrifice the kidney, which is not longer functional. Sacral roots and sciatic nerve involvement, I think this is not definitively a rare disease. And this is a new disease, and I think it is more and more frequent in my activity, but I think in all the tertiary referral center, these patients are more and more numerous. This kind of localization is suspected in patients with sciatic and pudendal pain, with dysuria and constipation, and the best exam is the MRI. So I think there is no other exam better than the MRI, and you can see here I put some images. You can see very well the size, the localization of the disease. For example, this patient is 36-year-old. So she has dysuria. She was not actually aware, but she has a post-voiding bladder volume of 300 milliliter. And you can see very well how the disease involves both sacrorectogenital planes. And I think that the nerve sparing will be very, very difficult and probably not feasible if we want to remove all the disease. Or this patient, you can see very well how the disease progress to the sciatic nerve. In this patient, the involvement of sacral roots is very, very well. So you can plan your surgery. Or in this patient with both involvement of the parameter, you can see that I had to shave the third sacral root. And it's very important to have a good idea about the surgery you will perform, because you can inform the patient about the risk, and also you can expect over all the difficulties you may encounter. And it is not a rare disease, because during only the last 18 months, I had 25 patients like this to manage in our center. So So I think it is a new disease, but it will be more and more frequent. Now the last question is, does the association of various exams actually improve the results? And we are about to perform a study, and Claudia Mehedințu is a colleague from Romania. So she was supposed to be here this morning, but she called me yesterday from Munich because the flight was cancelled, so she will be there this afternoon. So we prospectively recorded imaging data of 88 patients with colorectal endometriosis, with rectal nodule and sigmoid nodule. You can see they're rather large. And we try to understand if MRI is, if adding the computer tomography scan to MRI improves the sensitivity, the specificity, the concordance with the surgical data, and the measure of the estimation of the length of the stenosis. And here you have just preliminary results where you can see that the concordance of the association of two exams is better than the concordance of each exam taken separately. And in 80% of patients, we planned the procedure exactly, and we could do what we planned. So, take-home message: we have to start by we have to start by knowing, listening, and by a clinical exam of our patient. And we have to follow our clinical judgments and to understand why we ask an imaging exam and what are the findings we expect to have. And we have to give our clinical feeling and our clinical diagnosis to the radiologist, so the radiologist should not be blinded about what do you think, what do you expect to find. And also, we need a multidisciplinary team with very good radiologists, and we have to trust them, and they have to trust us. So thank you very much for this excellent experience in Iceland, and thank you very much.